A male in his 70s presents with a few-month history of breathlessness and weight loss. He eventually presents to the emergency department and goes on to have a CT pulmonary angiogram. The final diagnosis here may not be what you initially suspect. What's the diagnosis? Let's go through the case. Here we have a CTPA looking for pulmonary embolism, so we're looking for filling defects in the pulmonary arteries. Have a look at this normal study where we have the pulmonary trunk splitting off into right and left main pulmonary arteries. Here in our case, we can see large filling defects affecting all of these structures, highly suggesting pulmonary emboli. Once you see pulmonary emboli, don't stop there. It's important to check for a few other things. First, check for signs of right heart strain, assess for any features of chronic thromboembolism, and look for an underlying cause and look for an underlying malignancy on the CTPA. When it comes to assessing for right heart strain, one of the most useful things is to look at the ratio of the diameter of the right ventricle versus the left ventricle. If the right ventricle is larger than the left, we can say there is right heart strain, and this correlates well with echo findings as well as 30-day mortality risk from PE. Here there is also straightening of the interventricular septum. Then look for signs of chronic pulmonary thromboembolism. Right heart dilatation can be seen as we already have here, whilst we're also looking for occlusion of pulmonary arteries, eccentric filling defects rather than more central filling defects we see with acute PE, webs within the pulmonary arteries, reduced diameter and truncated segmental pulmonary arteries, and a mosaic perfusion pattern within the lungs. If this goes on to cause pulmonary hypertension or CTEPH, then we may see dilatation of the pulmonary trunk, which will appear larger than the ascending aorta on axial slices. In our case, follow these pulmonary arteries in the right lower lobe, and you'll see some are occluded. If we look at this slice, we will see compared to the left we have reduced vessel caliber and truncated segmental pulmonary arteries on the right, so we certainly think about chronic pulmonary thromboembolism in this case. Now assess for an underlying malignancy. So check the upper abdomen. There are subtle pancreatic malignancies I have seen on the bottom slices of a CTPA scan, so treat the abdomen as you would a normal abdominal CT. And check the lungs. Here we can see there are multiple lung nodules, the largest at the right lung base. A PET CT shows some of the nodules to be FDG avid. However, interestingly, if we look at the mediastinum, we'll see that pulmonary artery filling defects are avid. This now changes the differential. We would expect thrombus, which we'd see with chronic thromboembolic disease, to be non-avid on PET CT. The avidity here now raises the possibility of pulmonary artery tumour embolism. Usually we see this if there is another known tumour, and it has been described with atrial myxoma, renal cell carcinomas and osteosarcoma, whilst we also need to think about a primary pulmonary artery sarcoma. Either way, the lung lesions were likely to represent lung metastases, and the patient went on to have a lung biopsy, with the results suggesting an underlying sarcoma, meaning a pulmonary artery sarcoma was thought to be the underlying diagnosis. This is a relatively rare tumour, which arises normally from the pulmonary trunk. It mimics PE, and the diagnosis is not usually made initially, and only when the patient re-presents with symptoms and the pulmonary artery filling defects persist. On CTPA, we usually see a large filling defect within the pulmonary trunk, which occupies the entire lumen of the main pulmonary artery, and there may be mass-like expansion of the vessel. As in this case, we see high avidity of the filling defects on PET CT, although mild avidity has been described. MRI can be useful, and enhancement of the filling defects post-gadolinium can point towards a sarcoma. Unfortunately, prognosis is poor, as the patients present late when vessel occlusion occurs, and patients are usually initially treated for pulmonary emboli. And in general, when you find a positive CTPA, it's important to check for right heart strain, signs of chronic disease, and underlying malignancy. Pulmonary artery sarcoma is not a common diagnosis, however I have seen it more than once. If the filling defects are persistent and avid on PET or enhanced on MRI, then it's worth thinking about a pulmonary artery sarcoma.